time of data collection, I was a dental core trainee in oral surgery. This project was carried out at Eastman Dental Hospital, and it looked at the post-operative complications following dental extractions. I carried this out alongside my colleague Shree Patel, who was also a dental core trainee in oral surgery at that time. Hello everyone, thank you for attending and listening. The background of this audit was to assess the rate of post-operative complications. The first cycle began in September 2014, the second cycle began in September 2018, and the third cycle from September 2020. Our aim was to identify the rate and type of post-operative complications at the oral surgery department at the Eastman Dental Hospital, and to understand why our patients returned to the department for post-operative appointments. There are currently no set standards for a theoretical percentage return on patients for post-operative complications. However, studies do range from 4 to 6% and 30% for post-operative complications for mandibular third molars. Most of the data, however, is recorded for third molar removal in healthy patients, and as a bit of background from our previous cycle in 2018, an average of 3.02% of patients returned following treatment for a post-operative complication. We retrospectively analysed 250 randomly selected patients that attended for dental extractions to the oral surgery department under local anaesthetic, IV sedation or general anaesthetic. We looked at 50 patients per month between September to December 2020 and also noted the type of complication and the number of days after the initial procedure. This is just some background to show the findings of the first cycle in 2014 and the second cycle in 2017. All the figures range from roughly 1.5% to 5.5%. Looking at our third cycle of data collection in 2020, we found overall out of 200 patients, 13 returned with post-operative complications, and this was roughly 6.5%. The most frequent complication was dry socket or an infected socket which required antibiotics. We must also note that out of the 50 selected random patient records under general anaesthetic, 6% of those treated also returned with a post-operative complication and 2 required antibiotics. On the whole, we made sure to include a wide range of staff in our data collection. This incorporated dental core trainees, middle grade specialty doctors, specialty registrars, and also consultants. There was no clear correlation between job role and the incidence of post-operative complication, for example, a junior versus a senior colleague. Overall, we noted a 6% post-operative complication rate in our 2020 cycle of data collection, with the highest being in September 2020. On average, patients attended 8 days post-operatively, and a plausible reason could be that in September, COVID restrictions in the UK began to ease, our clinics became busy, and there were more surgical and complex procedures being carried out. This somewhat correlates with the incidences of higher post-operative complications within September 2020. If we look at the data, this then eased out compared to December. As a department, we wanted to know why these post-operative complications occur and also wanted to understand the patient experience. Our patients often stated they could not get through to us out of hours due to our service being strictly 9 o'clock till 5 o'clock. There is no on-call area for the oral surgery department, and this is taken over by our colleagues within the UCLH Max Fax department. Our medical colleagues took over any out-of-hour queries, and we should therefore consider advising our patients to see their general dentist for conditions such as dry socket. We also discussed standardizing when we prescribe antibiotics for an infected socket, for example, therefore eliminating operator bias. And we should also aim to make sure our patients understand the amount of post-operative pain, and we should avoid trying to underestimate this quality as pain is subjective. I then aimed to carry out an action plan and some recommendations. Further data collection was planned from February 2021 to April 2021, which was kindly collected and analysed by my colleague Shree Patel. We wanted to generate a smart text for our digital software in order to help standardise our clinical interactions and decision making during post-operative appointments. We also aimed to ensure that we were giving the same standardized post-operative instructions to our patients between colleagues, and also ensure that our patients were able to get through to the Eastman Dental Hospital, not our medical colleagues over at UCLH.
Cycle 4 was a re-audit, and this cycle was undertaken to establish the changes in post-operative complication rates following the pandemic. And following cycle 3, standards were the same as the previous cycle, and that previous cycle was undertaken in September 2020 to December 2020, with a 9% of patients returning with post-operative complications. So regarding method and sampling, this was the fourth cycle over a 5-week period. 416 patients were analysed. 40 patients that emailed in during this time frame had a concern and were sampled. On average, 33 patients a month were contacting the department for a concern. The type of procedure, clinical code, complication management were recorded. Were calculated out of the total patients treated during this time frame, and that was 416. Our key findings were that dry socket was the most frequent complication, with 13 patients out of the 40 patients that were contacted were diagnosed with this. 4 patients had post-operative infections, and then the remaining 6 patients came in with normal healing or post-operative pain. You can see that the ratio of treatment to dry socket is even amongst all staff members. The registrars do see more patients, therefore there's a higher number of patients that are contacted back. Dental trainees undertaking intravenous sedation have more patients with dry socket, but this could be because there's more time spent on teaching during the procedure. Overall, the staff member treating doesn't have much of an impact on the number of patients with post-operative complications. Here we can see that 25 patients out of the 40 patients were called in for a face-to-face appointment. 13 of these patients had dry socket, 4 patients had post-operative infection, but 6 patients had normal healing or normal post-operative pain. Others include patients with numbness and 1 other patient with poor healing. This slide shows revisits and causes. 4 patients revisited following a face-to-face appointment. 2 patients had normal healing of the socket. 1 patient required an examination under anaesthetic, and 1 patient had dry socket twice. Showed that our rate of complications is low and within the average quoted by initial studies of approximately 4%. New post-operative instructions have been introduced since the first cycle. Patients have a better understanding of what to expect and how to problem solve. Are we as a department explaining post-operative care better than previously? Or do we know if people did or didn't come in for post-operative complications? Showed that our rate of complications is low and within the average quoted by initial studies of approximately 4%. New post-operative instructions have been introduced since the first cycle. Patients have a better understanding of what to expect and how to problem solve. Are we as a department explaining post-operative care better than previously? Or do we know if people did or didn't come in for post-operative complications? So as we can see that during the COVID pandemic, during the first cycle undertaken and shown in this presentation, there was a rise to 12% of post-operative complication rates following the COVID pandemic, and once things settled down, our department saw a 4% in post-operative complications, which may have meant that patients were more liable to worrying about their surgical site, and maybe they were working from home and just had more time to have a good look at their surgical site as well. So this is something that we noticed as a department, and the following recommendations and action plans were discussed. So this includes to continue the use of forms to record the type and number of post-operative complications that the department sees. This is ongoing and should be completed for all patients. It is information that is required to be recorded and reported to. Number 2, the pro forma is useful and a simple measure to monitor, and we should therefore continue to use it. Number 3 is to investigate the type of complications that the department is experiencing and look into the data further to see why this is occurring. Consider if the extractions were complicated, surgical, and the grade of a clinician. Number 4, provide teaching to clinicians on how to improve good post-operative instructions or to ensure that patients understand this. We would want to ensure up-to-date teaching, which involves clinical teaching. So if the clinician is not confident with the procedure, that a senior is there to assist. And number 5, post-operative instructions. They have been improved since the audit started, so they are clearer for the patients, but it will also be important to get patient feedback on our post-operative instructions. Thank you for listening.
Thank you so much for your presentation.